Welcome to the Dr. Geo Prostate Podcast. Today's guest is Dr. Mohit Khera, a top urologist and professor at Baylor College of Medicine. He breaks down the latest on testosterone therapy, from the groundbreaking Travers trial to new oral options like Kyzatrex. We'll bust myths about testosterone and prostate cancer and explore bold new ideas, like using TRT for advanced prostate cancer. With over 160 publications and deep leadership in men's health, Dr. Khera delivers science with clarity. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, where it is my goal and intention and purpose to help you optimize your prostate health, your overall male wellness, and, how can we all live a little bit better with age? My guest today, Dr. Mohit Khera, needs no introduction, but the intro already happened. So, Mo, thanks so much for being on, brother.
Yeah, thank you for having me on the show.
Thank you. Mo, you're one of the world experts, global experts, as it relates to testosterone treatment, optimization of male hormones, always my go-to. So why don't we dive into that a little bit? I know that we can have a discussion for hours, but that's not what we do here. Maybe 1 hour, but we'll see. I think that you've been on a podcast before, and I had Helen Burney on, so I don't want to get into things that we've spoken about in the past. One of the main concerns that I have, right, is I see it all the time. Men go to these male clinics, and I just don't think they're properly taken care of the way they are being treated for. So they have, sometimes they don't even have a low testosterone. They get treated with testosterone, perhaps too much aromatase inhibitor. Sometimes they give them 5-alpha reductase inhibitors to lower their DHT. Maybe is appropriate, maybe it's not. So it's a little bit of the Wild West out there. I am going to talk to Justin Dubin about that and what to look out for. So we don't have to get into what to look out for here. But what are the different TRT options out there? And the reason I'm asking is because one form, the pill, Kyzatrex, which is the new kid in the block, seems a little bit interesting. And I know you've been behind some of that research. So the most common types, and can you talk a little bit about the pill options and a little bit on Kyzatrex if you can?
Sure. So listen, Gio, there's so many different types of formulations now. When I started my residency back in 2000, there was one gel, and that's all we had. And we had some injectables. And now you look, we can have almost 30 formulations that are available, and many are just generic. But the key is this. Someone says, which testosterone product is the best? And I say, look, testosterone is a compound. It doesn't matter if it's in a gel, injection, a patch. These are different delivery mechanisms for the same drug, right? So the same drug, just a different delivery mechanism. And one delivery mechanism may be better for you and one better for someone else. Many years ago, I came up with this concept called the 4 C's. How do you decide on which one's the best? The 4 C's are cost, compliance, convenience, and concentration. So cost, compliance, convenience, concentration. And everyone has a different formula for this. And some patients say, I can't afford it. Some people say it's inconvenient. Some people don't get a good concentration. So you got to find out what fits for the 4 C's for each one of the patients that you're treating. Now, let's talk a little about the different formulations because it's very interesting. And the hottest topic right now is the orals. The orals are excellent. Think about the history. In 1935, Gudin and Rusica actually first described the synthesis of testosterone. And that same year, they were describing oral testosterone. That was one of the first testosterones we ever had, was oral. But when Rusica developed oral, he noticed something very interesting. He put it into the body and it gets degraded very quickly. He couldn't keep it around. So what he did in that year was he methylated it. So 17-alpha methylation. And it was clever because if he methylated it, it would not get degraded by the liver, and it would sit around in the blood, and patients could get a benefit from the drug. The problem was that methylation caused hepatotoxicity, and it caused liver cancer in some cases. And so we were taught in medical school, do not give oral because it's going to cause hepatotoxicity. And that is true. The oral can cause hepatotoxicity. But something happened in the 1970s, which was really interesting. 1978, a drug came out called andriol. And andriol was the first testosterone undecanoate. And undecanoate means that it bypassed the liver and it went into the lymphatic system. But the only caveat was you had to take it 3 to 4 times a day, which is a hassle, with a fatty meal. So 3 to 4 times a day with a fatty meal, levels were okay.
And back then, the diets that were in vogue were the low-fat diets back in the 70s.
Low fat,
right?
That's
so
exactly right.
It must have been really difficult.
That's exactly right.
Yeah.
Very difficult. And if you think about what happened, most every country accepted andriol. Canada, Europe, Asia. The U.S. never allowed andriol in the United States as an FDA-approved product. So while the whole world had FDA-approved oral undecanoate, we did not get our first undecanoate until 2019, almost 50 years later. 50 years later. So 2019, we get our first oral, which is Jatenzo. And then in 2022, we get Tlando and Kyzatrex. And all three are excellent medications. They just have different side profiles, which we can get into. But what's really nice about the new orals is the following. One is that they only have to be taken twice a day. So that's pretty good, not 3 to 4 times a day. 2, they don't have to be taken with a high-fat meal. They just have to be taken with a meal. And it can be a low-fat meal. It has to be at least a low-fat meal. What constitutes low-fat? 15 grams of fat. Medium, moderate fat's 30 grams of fat, and high is 50 grams.
Even a salad, right? A little olive oil, and that'll do.
Avocado toast,
right.
You'll have your grams of fat, right? And so those are great. And now the best part about the orals is the following, the side effect profile. We worry about erythrocytosis.
And what does that mean in a simple language?
Sure. An elevation in your red blood cell count. And theoretically, if your red blood cell count gets too thick, then you're at increased risk, theoretically, for a cardiovascular event. So if it gets greater than 54, there's a theoretical risk. And we can talk about that later because I don't necessarily believe that, but it's a theoretical risk. So let's say I take an injection. The erythrocytosis rate's about 66%. A pellet's about 35%. A gel's about 12%. How about the orals? 5%. So you can easily get someone off an injectable, put them on an oral, and you drop the erythrocytosis rate, which is very nice. And it has a very nice hypertension profile. So all testosterone products cause hypertension. Don't be fooled. Every single one causes hypertension. But the hypertension with the orals is about 5%. And so it's very reasonable.
Mo, is the injections, it's all injections, the rate is about 66% across the board, or does that depend?
No, it varies. It varies, but injections have the highest rate of erythrocytosis because of the following. It's the spiking, and it typically, if you an older patient, so an older patient who's on an injectable will have a higher rate of erythrocytosis. And think about how we used to give 200 milligrams every 2 weeks. No good. 100 milligram every week, better. 50 milligrams twice a week, even better. So if you keep dividing the dose and lowering the spike, you lower the erythrocytosis rate. So in the old days, some people used to give, I see 300 or 400 milligrams once a month. Well, that's going to really spike them for the whole month. And it doesn't last that long anyway. So the reality is that you just got to be careful about the erythrocytosis. And the easiest thing you can do is switch someone off of an injectable and put them on an oral. And then you drop it right away. Do not forget, any patient that gets erythrocytosis, screen them for sleep apnea. Because many of them have occult sleep apnea, and testosterone tips them over the edge, and you start seeing some manifestations of recurrent erythrocytosis. So screen for sleep apnea.
What are you doing in your practice these days? What are you recommending, or does it depend? Are you recommending more pills than you used to, or does it depend? Sometimes injections?
Yeah, it depends. It's on the 4 C's. The reality is it's what suits the patient. Now, the only difference is that I do something different than what is recommended by the manufacturer of the orals. The orals will ask you to give the medication at breakfast and dinner. And I find that it's much better to give it at breakfast and lunch. And the reason being is because you superimpose that second peak onto the first peak, and you get majority of the medication during the day, and you mimic diurnal variation. If you take it at night during dinner, it will peak when you're sleeping. And I just find that it's more physiologic. I find that patients do better when they take it at breakfast and lunch. So that's what I do offer them, the orals. Sometimes they say, look, I forget the second pill. Okay, then let's talk about something else. Again, it's all based on the 4 C's. So Kyzatrex is cash only, and we are currently doing a study with Kyzatrex looking at fertility. We presented this at the SMSNA last year, showing that 80% of patients did not see a significant decline in spermatogenesis, but 20% did, so it's not 100%. But something in the orals is not suppressing gonadotropins completely, suggesting that you may be able to still make endogenous sperm production and testosterone. So more studies need to be done. I don't want anyone to think, hey, take Kyzatrex and you'll be fertile, but I do think that may not take as much of a hit as other exogenous testosterone products. Tlando is 1 dose, does not need to be titrated, 225 milligrams, no titration. And Jatenzo can be titrated and starting at 237. So they all have different nuances, but you find what's best for the patient. But, Americans are comfortable taking pills. I mean, they have pill boxes, they take pills.
I take about 25 pills twice a day, Mo. And most of the supplements.
So it's in our culture. I mean, like you just add it to the pill regimen and you take it.
Yep. Mo, how do the pills, so you already mentioned how do they differentiate from a fertility perspective? And by the way, full disclosure, Kyzatrex is sponsoring this podcast, this particular episode. So, but I want the right information to be transmitted to our audience. So if it's a young man who is 40 years old and is interested in being fertile, would you recommend in terms of pills, Kyzatrex versus the other two, or?
I typically have started with Kyzatrex historically because it's easy to get. There were some insurance issues initially with the other two. They're getting much better, but it's very easy for patients to just pay this one fee, no insurance, and historically would just get it to their house, And so that's where we initially started. And that's where I started my trials with Kyzatrex because there was when we started giving Kyzatrex initially, patients were not getting suppression of LH and FSH. I thought this is very strange. Because when I give patients other formulations, I shut down their LH and FSH. Why are they not shutting down the LH and FSH? And if it's not shutting it down, that means that it probably is not shutting down endogenous testosterone production and endogenous spermatogenesis, sperm production. And so we started the trial, and it's been going very well. And I think that when it ends, I think it's going to be favorable.
Mo, how about to the effect of what it does? So again, we have this conversation frequently with regards to what we're really looking for is a percent total of testosterone at about 2%, more or less. If that is,
you mean you're talking about the
percent free, right? Yeah.
Yeah. Okay.
Kyzatrex, in some of the preliminary research that I saw, tends to do that and tends to reduce the overproduction of SHBG, which is the compound, the protein that's connected to testosterone very tightly, and it doesn't let it free. What is your perspective on that? What is your research on that? And how does it compare to the other pills?
Yeah, that's a very unique property of the medication because it actually decreases the SHBG and increases the free T. So think about this. The body only cares about your free testosterone in terms of symptoms. It doesn't care about your total. And it's kind of odd because we spend so much time fixating on the total testosterone when we should be fixating on the free testosterone. So I have some very clever patients, and they come to me and say, Doc, I don't want you to give me testosterone, but I want you to lower my SHBG. So that's a very interesting thought. But SHBG predominantly is based on medical comorbid conditions. For example, hyperthyroidism will increase the SHBG. Hypothyroid decreases. Pregnancy increases the SHBG. Oral estrogen pills increase the SHBG. So there are some things you can do. Medical conditions, liver dysfunction, hepatocirrhosis can increase the SHBG. So there's a lot of things can increase the SHBG, but they're usually medical conditions. But you're right. Ideally, I would love to have a medication that would increase total testosterone and decrease SHBG. And that's what Kyzatrex does. That's exactly what it does. So I get a double benefit. I get an increase in the total T and a decrease in SHBG. So my free T just goes way up.
Let's move on to prostate cancer in association to testosterone. So I'll give you a summary of what I think I know. The more I research them, I give talks at the SMNA on natural things as well. And, our work, I think, is very humbling because I feel like the more I think I know, the sort of less I know, and to some degree, right? Or at least the more questions I have. Testosterone and prostate cancer. What I think I know is that there is no link between high testosterone and formation of prostate cancer. Some research suggests that men with low testosterone are at a higher risk of advanced prostate cancer at diagnosis. And in some cases, some men can utilize testosterone if needed after prostate cancer treatment, assuming that they're treated successfully. Can you fix that up if it needs to be fixed and kind of elaborate on that if you have to?
Yeah. Let's think about it in three buckets. Let's think about castrate, hypogonadism, and normal testosterone. So there's three little areas to think about. We were taught that testosterone increases the risk of prostate cancer. 1941 Huggins, based on one patient, if you pull the article. And subsequently, we found that that may not be true. In fact, if you look at the AUA guidelines in 2018, they state that patients should be informed that testosterone does not increase the risk of prostate cancer. And that was a strong recommendation. So that was important based on the literature. So it's very safe to say that testosterone does not increase the risk of prostate cancer. But now we're talking about some different topics. Let's talk about patients who have a history of prostate cancer, radical prostatectomy, radiation. How do you address those? And that may be a little bit different. The AUA guidelines state that those patients should be informed that the risk-benefit ratio is unknown at this time. It is true, we do not have a large randomized placebo-controlled trial, although Hopkins, I think, is going to be publishing theirs very soon, the first randomized placebo-controlled trial on testosterone and radical prostatectomy, but we don't. But if you ask urologists and look at trends from 2006 to even 2016 in that 10 years, most urologists feel very comfortable now giving men testosterone after radical prostatectomy. 2006, when I finished my fellowship, 2007, they did not. So the times are really changing in terms of the comfort level. Now, we're starting to see an era where testosterone may be therapeutic or protective against prostate cancer. That's an interesting thought.
All right, let's pause there because you're saying that you're saying something very significant here that I don't think the audience knows about. This is an area. Are you talking about bipolar androgen deprivation therapy, BAT, known as BAT?
Yeah, bipolar androgen therapy, and that's therapeutic. And then I'll talk about protective. If you look at Tom Allering's data, Stacey Loeb's data, looking at Stacey Loeb works with you, she had a very nice registry study showing that, and even some of the newer data out of Dr. Mulhall's group, and even a recent abstract from Helen Burney as well, showing that potentially those patients who take testosterone might have a decreased biochemical occurrence. We published the same thing as well. So maybe protective. And my personal opinion is the following. I call it the inverted U. If someone has a history of prostate cancer, castration may be helpful. There are some data that castration may be helpful. And actually raising the testosterone into the normal range may be helpful. The danger zone is the hypogonadal range. So if I had prostate cancer and I was hypogonadal, either castrate me or put my level into the normal range, but I am not sitting.
Define hypogonadal. You've been taking care of your health, regular checkups, staying active, trying to do all the right things, but lately you've noticed something's changed. Maybe you've more tired than usual, your motivation dropped, or your strength and stamina just aren't what they used to be. These all can be signs of low testosterone, a condition that affects nearly 1 in 3 men in the United States. Kyzatrex is an FDA-approved oral testosterone replacement therapy that helps restore testosterone levels back to normal. It's not an injection or a messy gel, just a simple twice daily pill that fits easily into your routine. Find out where you stand. Order a testing kit today at kyzatrex.com/testing-kit. Or look at the link below in the show notes. By prescription only, Kyzatrex is a controlled substance and can be a target of abuse. Kyzatrex is not for use in pregnant women or men with prostate or breast cancer. Safety and efficacy in those younger than 18 is not known. Tell your doctor about all medications and conditions. Serious side effects could include increased blood pressure, worsening prostate problems, increased risk of prostate cancer, blood clots in legs or lungs, liver problems, enlarged or painful breasts, and breathing problems while you sleep. Common side effects include swelling of the ankles, feet, or body, increase red blood cell count, and increase PSA levels. PSA is a test used to detect prostate cancer. Report these symptoms to your doctor. Call your doctors to learn more about Kyzatrex. For questions or information, visit www.kyzatrex.com or call 1-833-949-5040.
Testosterone less than 300, I would even see testosterone less than 350,
Okay.
right? Castrate less than 50. There that zone is dangerous. It's a very dangerous zone. And I would say that, we will talk about bipolar androgen therapy. I mean, that just blew my mind. 2015, Schweitzer out of Hopkins, then Mead showed that essentially it was a small series. It was 14 patients at risk of prostate cancer, gave them high doses of testosterone with 400 milligrams of testosterone every month with anti-androgens. So the T would go up and it would crash. And essentially what it would do, it caused a 50% reduction in PSA and a 50% reduction in metastatic disease. Unheard of to give someone testosterone in the setting of metastatic prostate cancer. But the clincher was the Transformer trial. That was the most amazing trial. These are patients, 100 on each arm, receiving either enzalutamide, which is standard of care in someone who becomes resistant to abiraterone, or they receive BAT. So remember, someone's castrate-resistant prostate cancer, they failed abiraterone, they're supposed to get enzalutamide, and they say, wait a minute, instead of giving you the standard of care, which is enzalutamide, let's give you high doses of testosterone, half of you, and just see what happens. And if you fail that arm, then we'll let you do a crossover. What they found was that whether you gave bipolar androgen therapy or enzalutamide, there was no difference in overall survival. No difference. And if you gave someone BAT first and then allowed them to switch to enzalutamide, they had greater survival than enzalutamide alone, which is the standard of care, right? Enzalutamide, $7,500 a month. Testosterone at high doses, about $50 a month, right? And who had a better quality of life? The testosterone patients, right? So it's just a different way of thinking that to be giving testosterone to men to treat them for metastatic prostate cancer. Now, we're not that smart because if you pull Huggins' article in 1965, you're going to read something very interesting. He says in that article, taking away testosterone or hormonal excess, which he termed hormonal interference, may be used for therapeutic benefit to treat men with prostate cancer.
Who was that?
65. Huggins,
yeah.
the guy.
Really? He did say that. Wow, I didn't know that.
In 65, and so 1941, he gets the Nobel Prize saying it's dangerous. He writes that it's dangerous and it causes prostate cancer. In 65, an article he writes says high doses may be used for therapeutic benefit. And we are crickets. We don't talk about it. We don't say anything for 50 years. And then we realize, yes, there may be used for therapeutic benefit.
Wow. Okay. All right. There's a few things to unpack there. So how advanced, so we're talking advanced. So let's break this down. Man on active surveillance, hypogonadal, gets on testosterone, no problem. Or at least there's no association between advancement of that cancer and testosterone therapy. Men who perhaps has intermediate risk gets treated successfully with anything, radiation, prostatectomy, whatever, hypogonadal, they get treated with testosterone, no problem. Men with advanced prostate cancer, however you want to define advanced, whether it's Gleason 9 and no recurrence yet, or metastasis to the local area of the pelvic, lymph nodes, or to the bone, testosterone treatment in this utilization of BAT is potentially an option as well?
It is, but listen, this is very
Yep.
important. Everything comes down to counseling. Everything comes down to counseling. And it's a risk-benefit ratio. And I don't tell patients, take it and everything's perfect and don't worry about it. That's not what I tell them. I say that the risk of prostate cancer progression and recurrence is unknown at this time. We don't have large trials. Clinical experience with myself and amongst others has not seen an increased biochemical recurrence, but we have to be fair on the data. We have to be fair on what data I have. And I tell them that whether I give them testosterone or a sugar pill, their risk of biochemical recurrence is very high, much higher than others, right? So we have to understand that if they do have a biochemical recurrence, I don't want them to second guess that it was the testosterone. I wouldn't give them the testosterone if I thought it increased the biochemical recurrence. Let's be very fair. And quite frankly, I personally think that it may decrease biochemical recurrence, but I don't say it like that because I think we're not there yet. But I do think that. But I do tell them that you have a higher risk for biochemical recurrence, and you have to weigh the risks and benefits of the medication. And some patients will say, I don't want to take the risk. I say, okay, great, then let's not take the risk. That's perfectly fine. And others will say, no, my quality of life is so poor, and I felt so much better when I was taking the testosterone that I would like to take the testosterone again. And I understand what you're saying. But I really feel like it comes down to counseling. And you don't want to sell someone on it, particularly when they're at high risk. You really want to just give them the facts. I love the shared decision-making model. We come down and we make it together. But I think it's very important the way you counsel the patient, particularly the high-risk patient, and particularly a high-risk radiation patient, right? Because those PSAs are going to rise because they were on androgen deprivation therapy. Their testosterone was below the saturation point, and you're going to have to stomach that rise in PSA and explain to them that it's going to plateau. And as it keeps rising, the patient's getting anxious, the oncologist is getting anxious. They're asking you what you're doing, and you're going to say it's supposed to plateau, and it does. But you have to counsel that it's going to rise.
Wow. Okay. So who is doing this? Because other than you, certainly no one in my department, I don't think, is willing to prescribe testosterone in patients with advanced prostate cancer. I just don't know many who are. So the listener saying, oh, this sounds great. Where am I going? Right. So
yeah, but I want to clarify, when you say advanced prostate, I'm talking about a history of advanced prostate cancer that was treated. I am not doing BAT or bipolar androgen therapy, meaning someone has metastatic disease, advanced prostate cancer, and giving them high doses of testosterone. I will send them to Dr. Denmead at Hopkins, which I have, but I will not treat someone who is high risk, active prostate
without
cancer
being treated. So how stable do you need the prostate cancer to be? So let's say, what if they have a situation when they've been on ADT for more than 2 years and now they're castrate resistant? Is that a good patient?
If they're castrate-resistant prostate cancer, I'm not going to treat them with testosterone, right? So if someone with metastatic disease, I will ask them to join into a clinical trial, right? So if something with metastatic disease, I will say to them, and I tell them where the trials are, you can go and enter into a clinical trial. So what I'm referring to is someone who's had treated prostate cancer, but he's still high risk. I mean, if he had a Gleason 9 and he was treated, he's still at high risk for a biochemical recurrence. And I'll explain to him what I explained to you earlier about the counseling. I think counseling is everything. But as I mentioned earlier, the most difficult part is the high-risk patient who's been treated with radiation, who's been cured, but he had 2 years of ADT or 18 months of ADT. And you're going to see a rise in that PSA at the beginning, which makes it a little difficult. I typically like to wait 18 months. I'll just tell you, it takes 18 months to get complete cell kill from the radiation. So I won't go so early on the patients with radiation, particularly at high-risk XRT patients.
Even if what if they are still on ADT? Because sometimes they leave them on ADT for 2 years. Would you apply BAT in that situation or no?
No, I wouldn't. I mean, it doesn't make any sense to me. If they're on ADT and it's been 18 months, I could make the argument to stop the ADT and let's see how much you rise. Sometimes you're lucky. Sometimes there are cases, younger patients can have a rise back into the normal range, but typically 2 years of ADT and the older patients will not see a significant rise back into the therapeutic range. And so we just put them on. I want to stop, see where they end up, and then we can discuss raising their testosterone. I would not put them on a pellet. Just want to be very clear. You can't take that out. You want to use a short-acting testosterone and something that can get out of the body pretty quickly if the patient has any concerns.
All right. So a lot of the patients and a lot of the comments on the podcast, I answer the question, or I try to. If testosterone is not the issue, then why are they recommending androgen deprivation therapy? What's the answer there? Advanced prostate cancer, of course.
It's the inverted U, so if you think about it, castrate has some benefit. We did a lot of this work in our lab as well. Castrate does slow down prostate cancer cell growth. It does. And hypogonadal range actually causes it to accelerate. We did this in Petri dishes. We showed the acceleration. But as we gave higher and higher doses of testosterone, it actually caused greater and greater suppression of prostate cancer cell growth. So that was our first study, looking at LNCAP cells in different concentrations of testosterone. The second one we did was quite larger. We took 200 mice and we put them either in control, hypogonadal, and then we put them on low dose of testosterone, or we put them on high dose of testosterone. And we saw the same thing. If you castrate the mice, it actually causes a decrease in prostate cancer cell growth. We put LNCAP cells in the back and we'd watch them grow. If you gave low dose of testosterone, you saw a significant increase in prostate cancer cell growth. And when you gave high doses of testosterone to the rats and mice, it actually caused a suppression. The inverted U, it mimicked identical to what we saw in vitro in our lab. So I do think that there is some benefit in castrate. That is true. But if you look at the overall improvement in survival, it's marginal. I mean, even if we look at our chemotherapeutic agents, all the drugs we have, we're not talking many years of survival increase. And, what does ADT really do? There's sequela. There's cardiovascular sequela, metabolic sequela, right? Cognition, quality of life sequela. And quite frankly, it does suppress the PSA, so everyone's quiet and happy. But there's no significant, I would say, overall increase in survival. And I would say that, is it really worth it when you look at all the sequela and quality of life?
Is the problem with any association with testosterone and prostate cancer not testosterone, but the androgen receptors that are sending signals to tell the cells to grow faster? Is it an androgen receptor issue rather than a testosterone issue?
I think it's a combination of both, right? You need both. You need the testosterone, you need the receptor. The problem is that the receptor, when it becomes castrate resistant, then you have a problem. One of the theories about BAT, which is quite interesting, and I think it's interesting, is that it can convert castrate resistant testosterone, prostate cancer cells to sensitive, androgen sensitive. And so basically from androgen insensitive to androgen sensitive, and when it becomes androgen sensitive and then you take the testosterone away, it drops the PSA, right? And so that is a theory of why BAT may be effective. There's several theories why BAT may be effective, but I think it's just fascinating. I mean, who would have thought 20 years ago, a guy walks in with metastatic prostate cancer and we're going to treat him with high doses of testosterone, and he's going to start seeing a reduction in his PSA. He's going to start seeing a reduction in metastatic disease. And theoretically, you may see an improvement than even standard of care, which is enzalutamide, which is high doses of testosterone. You would have never thought that, even 10, 15 years ago.
Yeah, fascinating. Let's go back for a second as it relates to the potential risk of high testosterone and prostate cancer. Are there any genetic differentiations that maybe, 90% of the time no risk, maybe 10% of the time there is? I could tell you maybe 2 patients I've seen within the last couple of years in their early 60s. The only association that I can see, obviously there's always a lot of variables involved, was that they began testosterone, then the PSA jumped and they had advanced prostate cancer. That doesn't mean they didn't have it before the TRT, but again, it showed from a PSA, and physician who treated them got a baseline PSA that was normal, and then they were on TRT, and then it rose up rapidly and they had advanced prostate cancer. Again, we can't say that caused it, but aren't there genetic variants, for example, and maybe you can expand on that, CPG, length, and TMPRSS2, and some other epigenetic elements, even AR, androgen receptor, genetic predispositions that may, in some patients, it may stimulate the production of prostate cancer?
So let's answer both of those questions. Let's think about the first patient for a second. The patient, you said they got the testosterone and then had high-grade prostate cancer. I don't think personally that it causes high-grade prostate cancer, but it can unmask someone to do a biopsy, for example. Because remember that if your starting testosterone is less than 250, you're under the saturation curve. And so let's say the PSA was 0.5 and he had a testosterone of 190, okay? His real PSA is not 0.5, right? It's really not, because it's underestimated because his testosterone level is below the saturation point. Some people would say 250. Once you normalize his testosterone, you will see a rise in PSA, no question. And all you're seeing there is a hypovolemic prostate getting to the euvolemic state, and you are seeing what the true PSA should be. So when you and I and when clinicians look at that, we say, oh, there's a rise in the PSA, and that's a significant rise. Let's get an MRI. Let's do a biopsy. then we find the cancer. And I think that it forces us to look when we start them on testosterone, but I don't think it's causing the cancer. That's me personally, right? It just forces us to look because the PSA is going to go up. And we say, oh, the PSA went up. What should we do? And so in some ways, it may be a beneficial benefit because delaying that would have been a problem down the road, right? Delaying that and not having that rise in PSA and not making you act upon it could have been an issue. I really can't comment on those genetic markers that you said. I can't. I just don't think that it is causing prostate cancer in men that we give testosterone. Now let's think of this another way. Let's think about all the studies that were done giving men testosterone. And you look at every study giving men testosterone, and you look at the rate of prostate cancer, and you look at the general population. There's not a single study that shows that men getting testosterone have a higher rate of developing prostate cancer than those men not taking testosterone. But the story gets more interesting because you and I know that if you and I went to the biopsied everyone outside in the waiting room tomorrow, 1 in 6 men have occult prostate cancer, minimum. In fact, some studies would say if you go to the morgue and do an autopsy, you will see 1 in 3 men have prostate cancer. They didn't know it. So what am I doing? If I say, Gio, if you treat 60 men in your practice with testosterone, I promise you, you're giving 10 men with active prostate cancer testosterone. And not a single study has shown that they lit up. Not one, decade after decade. So here we are with all these men with prostate cancer. We're dumping them with testosterone, but for some reason, they don't light up more than the average population. So what's the explanation? I don't think testosterone causes prostate cancer.
And so even with any of these genetic variants, you don't think there's an association?
Well, we would have to say that some of those genetic variants have to be in the general population of all the studies that we've treated men with testosterone. Those would have to light up.
I see.
One way or the other. They would have to light up, right? But never have we been able to show in any trial, even the Traverse trial, just got released, right? 5,246 patients, right? Half the testosterone, half the no increased risk in prostate cancer. Some of them may have the variant, right? But no increased risk, right? So I just, and the AUA guidelines in 2018 were very strong. It wasn't a moderate or weak, it was a strong recommendation. Patients should be informed there's no increased risk of giving men testosterone for prostate cancer. Now, the second bullet underneath that says, if they have a history of prostate cancer, the risk-benefit ratio is unknown. Fine. But you and I are just talking about the general population and the risk of prostate cancer. No compelling data to support that.
You talked about the Traverse trial. In every conference is mentioned, any conference related to a hormone or a chronological conference as it relates to testosterone is mentioned. What it showed was that there is no association. The primary outcome that they were looking for is association with cardiovascular disease, and showed that there is no association, or at least it doesn't increase the risk of cardiovascular disease in men on testosterone. Is that correct?
That's correct. 7% in the placebo arm, 7% in the treatment arm.
Do you suspect the type of testosterone that was used was the topical? I think it was androgel. Would you suspect that any other form would change those numbers at all, or not?
That's a great question, Gio. That comes up in every conference, that question, right? And I would agree that the injectables have inherently different properties, and maybe it could have a different outcome. The injectables do have a higher rate of erythrocytosis, as I mentioned earlier. I would say that they have a higher rate of sodium retention. They have higher levels, right? The levels are higher, and it could be different. I'm not saying that it's a possibility. I think that the other formulations like the orals are more similar to the gels, and the safety profile is fair, but the injectables could have a different side effect profile.
Do we know from the Traverse trial that so the trial's been going on for how long?
It was a 6-year trial. It's finished.
Okay.
It's finished. It was the last publication we had 2024. We started, and all 7 studies have been published.
6-year trial. And there is no, so the association between androgel and prostate cancer, that has been published already?
It's been published, yes. It was a subset of the
Great.
trial. And so it showed the two important things: no increased risk in prostate cancer, no increased risk in high-grade prostate cancer, and probably more importantly, because we knew that no increase in BPH or LUTs.
I like
And
that.
remember that all the patients, all of them got an IPSS questionnaire, and it's 5,246 patients, and we ran, and so basically showing that testosterone, because in the package insert, if you read it today, right now, under the warnings and precautions section, it says, be careful in giving men testosterone because it may cause a worsening of BPH symptoms. And that is the first bullet. And but there's no data to support that. In fact, the only data to support that is embryology. If you look at embryology at a fetus, and if you look at the male fetus, without testosterone, the prostate does not grow at all. So, but that's never been shown in the adult male. Even before the Traverse trial, it was never shown in the adult male. In fact, if you look at one of the best review articles by DeLay and Kohler, either testosterone had no effect on BPH and LUTs, or it improved BPH and LUTs the longer you gave it, because testosterone is a strong anti-inflammatory. But the Traverse trial just solidified that. It says, again, there was no worsening of urinary symptoms. Now, Gio, there's an exception, and we should know about the exception. The exception is if you have a man who starts out with a very low testosterone level. I mentioned to you earlier, it's the hypovolemic prostate getting to the euvolemic state. Starts out with low testosterone level, below the saturation point, his prostate will grow at the beginning to get the euvolemic state. And if he already has bad BPH, it's going to get a little worse. I just want you to know that at the beginning. But if you treat him long enough, up to 12 months, it's going to get better and better and better. But those men who start out with very low T levels and have significant BPH, just a little bit of caution.
So men with that are hypogonadal, what are we talking about? Less than 350 according to Mohit Khera?
Less than 250. I think the saturation, but every man's different. So 250 is just a general number. But let's say he was at 200. That's safe. He had a 200 T, and he had pretty significant BPH, lower urinary tract symptoms, large prostate, 60 grams. He's going to get a little worse at the beginning.
But stick to it, and
it will get better all the time.
Because
if you look, the Haters trial, they got worse at 3 months. It went up, got worse. And then right after that, got better and better and better every 3 months, better than baseline, right? So it got worse at the beginning, and then it just kept continuing.
Yeah, it's one of the best and biggest trials, I believe, on TRT. Should we assume that if they were to study those patients on TRT versus placebo, 10 years, 15 years, 20 years, that there might be prostate cancer development at some point, or at this point, after 6 years, you're saying highly unlikely, or at least highly unlikely is associated with the TRT?
I think it's highly unlikely. We have many clinicians now that have been treating patients with testosterone for 40 years. I mean, Abe Morgenthaler, so many people, and we don't see a significant increase in those men being treated with testosterone. I would argue that you may see a decrease in prostate cancer occurrence in those men who normalize their testosterone. Again, that more studies need to be done.
Sure. I mean, I guess that's the question. It's like, what is the association in 10 and 15 and 20 years, right?
Yeah.
Rather than increasing the risk necessarily. Yeah.
Yeah. I mean, you have Klinefelter patients. You have many patients who are started on TRT from a young age because they don't make testosterone. We don't see an increased risk in those patients over long periods of time. As I mentioned earlier, testosterone's been around for 80 years, right? So it's been a long time. And that's right. So I mean, we don't see an increase in risk. I will tell you this though, and this is a very important thing. Testosterone is the best barometer of a man's overall health. There's not a better test than a testosterone level to assess his overall health. Because think about this. We talked about low T affects your energy and your sex drive and your libido and your energy, like all the things that affect your quality of life. But we didn't talk about other 5 big things. We know that low testosterone is strongly associated with cardiovascular risk. Non-negotiable. That's in the guidelines. Low T, increased risk for heart attack. Low T, increased risk for depression. Low T, increased risk for osteopenia, osteoporosis, bone fracture. Low T is associated with metabolic syndrome, diabetes, obesity. Low T is associated with prostate cancer. It doesn't cause, I'm just saying it's associated with prostate cancer. So look at all these conditions that men suffer from and look at all the quality of life. Now show me another blood test that's a better indicator of his health. It's not his TSH. It's not his hemoglobin A1C. It's not his lipid. I mean, you show me one blood test that's a better indicator of his overall health. It does not exist. It's testosterone, right? But testosterone is not a standard screener. And when you go in for an exam, every man over the age of 40 should have a testosterone level checked every year. It's a $39 test, as you do it at Quest. $39 every year you should have it checked. It's a best barometer of not only your current health, but your future health, right? What's coming down the road. And I think it's very important.
Mo, what's the panel that you order? So it's not just total testosterone. So for example, I like to look at total free. I like to look at SHBG, DHT, and estradiol, and see the ratios between all these and so forth. What do you look for?
I look exactly what you looked at because remember, T is broken down into E and DHT, so that's important. So you want to, and once you start them on therapy, you want to see how much you're converting. So that's very important. Both E and DHT have adverse effects, meaning gynecomastia, mood stability, alopecia. So you just have to look at what you're converting into. So you wouldn't know much if you didn't have a starting point. So it's good to know what DHT and E you started with. Remember, this is not in the guidelines, so this is something that I do. The guidelines would not advocate a starting DHT or an E level. But I look at other things. For example, a lot of these patients come in with low libido. It's kind of a common thing. But low libido has its own mnemonic, and I teach the residents the mnemonic PET: prolactin, estradiol, thyroid, testosterone. Prolactin, estradiol. If someone comes with low libido, check the PET. It's actually very important. You're missing one of those because either one of those any of those can cause a low libido. And then we'll check an IGF-1 level. I think there's some data support. We've actually published this on too, that increasing IGF may help with sexual function. It's called the stable marker for growth hormone, right? And I don't believe in giving growth hormone, but I will give someone a peptide to help raise their own endogenous natural growth hormone levels. And then check for all the things that could mimic hypogonadism. I'll tell you a very interesting story. I gave a talk to the psychiatrist, and I talked about our data where we showed that 92% of men who had low T suffered from some degree of depression. 17% had severe depression. We treated them for 1 year. 17% dropped to 2%. And I said, hey, I'm not advocating to treat major depressive disorder with testosterone. But what I am advocating for is to at least check a testosterone level in men who present with hypogonadal symptoms or depression. And they said, Mo, that's great. We agree with you that we should check a testosterone level in men who present with depression. But here's our problem. When a man presents with hypogonadism, you don't screen him for depression. You don't give him a PHQ-9. And I said, that's right. Maybe he's depressed and I'm thinking about hypogonadism, so I now screen. And the same patient with the same symptoms same patient who walks in with the same symptoms walks in the endocrinology clinic. What do you think? They just say, what's the TSH? So each professional is focused on their silo. TSH, depression, or a T. And what we should be doing is checking all of them, right? So now we give a PHQ-9, we check the thyroid. So I think it's very important to remember that hypogonadal symptoms are nonspecific, and he could be suffering from something else, and you need to take a deeper dive.
I agree. I definitely agree. Back to the Traverse trial just for 1 second. Did I misread this, or did they notice that there was an increase in fractures in those on TRT versus placebo? And if so, why do you think that happened?
Yeah, it was a 1% increase. So we got caught off guard a little bit. 1% increase in bone fractures in those men who took testosterone over placebo. Now, let's think about how testosterone affects bone mineral density. It doesn't happen overnight. In order for me to increase bone mineral density, most studies would say 6 months on average when you start seeing the first asterisk of statistically significant increase in bone mineral density. So most of the fractures that occurred were acute fractures that happened early on. They weren't low impact fractures that you see with patients with osteopenia and osteoporosis. Many would argue that if you give someone testosterone, you could increase their activity. We've seen that in many other studies. You increase someone's activity, you're more likely to have a fracture, right? So they were early on, they were acute fractures. And remember, we didn't have baseline DEXA scans, or we didn't have baseline levels on all these patients. So we don't know who was more likely to have a fracture or not, right? So it was an interesting finding. It was 1%. But again, the type of fracture was not the typical osteopenic fractures that you'd see.
I guess my last question is, do you ever aromatase inhibitors? I know that even when estradiol levels are high relative to testosterone, as long as there's some decent ratio, maybe 40-1 or so, I don't necessarily, I'm not a big fan of aromatase inhibitors because you do need estradiol. What's your approach with regards to estradiol, and do you ever decrease it for any reason?
Yeah, so when I was starting my fellowship in 2006, my mentor we were taught to give Arimidex 1 milligram a day and just make the estradiol low because we were taught men don't need estrogen. It's women need estrogen and men need testosterone. And we figured out several years later we were wrong. Men desperately need estrogen, particularly for sexual function. And Finkelstein's article showed that it was actually mostly the estrogen effect, not the T, that was actually giving the benefit. So we realized we're not going to shut the estrogen down. We're going to manage it. We're going to put it in the sweet zone. And just like any hormone, and Gio, this is important, all hormones in the body love to be in the middle. You don't do great when your hormone's low, and you don't do great when your hormone's high. It's the center. You want to be in the center. Pick any hormone you want. It's the center where you do the best, right? And the same goes with estrogen. My range has historically been between 30 and 50. When you drop below 20, even below 15 on the estrogen, that's when you have the increased risk of osteopenia, osteoporosis. So you don't want to give someone long time doses of estradiol because it will shut down their estrogen. I mean, aromatase inhibitors will shut down their estrogen. So I manage it. So a lot of the clinics, when you go in, they give you, I call the trifecta. What's a trifecta? They give them T, HCG, and Arimidex. They give them all three and they send them out. And I say, why would you give him Arimidex if you didn't even check the E? Maybe he never needs it. Why don't you see what the E is before you give him the Arimidex?
Yep.
So I'm not a big believer. I like to give him 0.5 milligrams a week, check what it is, maybe give him 0.5 twice a week, but you manage it. You don't shut it down.
5-alpha reductase inhibitors that reduces DHT, as if DHT is just the enemy. What's your, it's almost like the cholesterol story. Sometimes I see patients with, they increase their statins until their cholesterol is less than 100. Meanwhile, you need cholesterol even to make so many of these sex hormones. I'm getting on a soapbox here because it's frustrating for me. So what's your approach with DHT? Do you ever prescribe 5-alpha reductase inhibitors?
I don't prescribe them at all. Not at all. Not for BPH, not for alopecia. I don't think they're a good medication. I'm a little biased. You and I were taught that testosterone is converted to DHT, and if I give a 5-alpha reductase inhibitor, that I block that conversion. What we were not taught is that there are 11 other pathways that are blocked, not that one only. 5 of the other ones, and then 6 neurosteroids are blocked, no question. But those neurosteroids, like allopregnanolone, have been implicated for anxiety and depression. And many patients who've taken these medications have had increased suicidal ideations, increased suicides, so much so that many countries, except the US, have now put warnings on suicide and suicidal ideation in the package insert of 5-alpha reductase inhibitors, right? And I just feel that any drug that can have that effect, I don't care what it does on the hair or the prostate, I just don't feel that it's safe, and I don't advocate it at all.
Yeah. Well, you're preaching to the choir. That's why I'm happy and bald. Mo, thank you so much for your time and your generosity with your time and educating me, as always, and the audience. So I always appreciate you, brother.
Thank you, Gio. Really enjoyed it. Thank you for having me on your show.
My pleasure. Final words, and how can people find you? I think that people will be flying to see you moving forward. So how can people find you?
I'm at Baylor College of Medicine and happy to help in any way here in Houston. I think that's the easiest way to find me here in Houston. Yeah.
Parting words, any final thoughts from the guru on this topic?
Yeah. I just think it's important to realize that testosterone is really the best barometer of your overall health. If you haven't checked your testosterone, check your testosterone level, see what it is. It's a great marker of what your health is today, but more importantly, what your health will be in the future. and take it seriously.
Right.
Because treating can be beneficial.
Right. Ask your physician. He's going to do a blood draw. He or she going to do a
Yeah.
blood draw. They're not thinking
Yeah.
testosterone. So you may just
Yeah.
want to nudge them and ask them, hey, can you include a hormone panel that includes
That's right.
testosterone? Yeah. So,
That's right.
so where to go?
It's so simple. It's so simple. You nailed it. You're already drawing the blood. Just add
Right.
it. It's not expensive.
Not expensive.
Yeah.
Mo, thanks so much. Much love to you.
Thank you so
All
much.
right, thank
Gio.
you. Thank you, everyone, for watching or listening, depending on how you're consuming this information on testosterone, and particularly with its relationship to prostate cancer. This is probably information you're not hearing anywhere else. Thank you so much for tuning in. Thank you for being a part of this, the Dr. Gio Prostate Podcast. I appreciate you as always. Don't forget to like, subscribe, and do all those things. That always helps. This is Dr. Gio signing off. I'll see you next time. Much love. Talk to you next time.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.